Welcome to our Friday Journal Club. I'm JP Brito, one of the co-hosts of this virtual series. Today, we're going to talk about thyroid cancer management and diagnosis before, during, and after pregnancy. And for that, we have a fantastic panel. Our speaker, Dr. Evert van Velsen, will start with the presentation and then followed by Dr. Davies. And our expert discussant will be Dr. Brett. But before I introduce each member of the panel, a very brief reminder to the audience that you can submit your questions at any point during the presentation. Our staff will send those questions to me and I will bring it to the panel at the end of the presentation. So let me start introducing first our expert discussants, Dr. Red. Dr. Red is a board-certified endocrinologist in New York City. Her practice is a private practice in the Upper East Side where she offers personalized care for adult patients. She practices general endocrinology and has a special expertise and certification in thyroid ultrasound and fine needle aspiration biopsy. In addition to her private practice, Dr. Red is an associate clinical professor in the Icahn School of Medicine at Mount Sinai and a voluntary attending in the Mount Sinai Hospital and Lenox Hill Hospital. She has lectured nationally and contributed to several books, clinical practice guidelines, and scientific papers on the topic of diabetes, thyroid disease, nutrition, adrenal disease, and obesity. She served for many years on the board of directors of the American Association of Clinical Endocrinology. Then we have our second speaker and also expert discussant, Dr. Terry Francis Davies. Dr. Davies is the Florence and Theodore Van Ritter Professor of Medicine at the Icahn School of Medicine at Mount Sinai in New York and director of the Division of Endocrinology at Mount Sinai Beth Israel Medical Center. Dr. Davies has been trained in the UK and University of Newcastle. And after further research experience at NIH, he ended up at New York and Mount Sinai. He's a very distinguished record of significant contributions that is well known by many of us, has published more than 400 scientific papers, and mostly concerning thyroid disease in the areas of immunology and genetics, and in the clinical arena as well, in the area of autoimmune thyroid disease and autoimmune thyroid disease in pregnancy. The Davies Laboratory remains one of the preeminent sites for autoimmune thyroid disease research, as evidenced by his extensive support from the NIH since 1980 and from the VA research program. And finally, let me introduce Dr. Evert van Velsen. Dr. Van Velsen has been here as a speaker before, so thank you for coming back. Dr. Van Velsen studied computer sciences at Utrecht University in both clinical epidemiology and medicine in the Erasmus University in Rotterdam. Currently, he's an internist endocrinologist in training and a PhD student in the Department of Internal Medicine and the Erasmus Medical Center. His research, under the supervision of Dr. Professor Peters, is mainly focused on prognostic factors of differentiated thyroid cancer. And with that, I will pass it over to you, Dr. Van Velsen, to start our conversation. Thank you.
Yeah, so thank you for the introduction and also thank you for the invitation to tell something about thyroid cancer in women of reproductive age and the perinatal period. So indeed, I'm from the Rotterdam Medical Center. So I have nothing to disclose. So the last decade, the incidence of thyroid cancer is rapidly increasing. You can see here in this graph, which is mainly caused by the increased detection of small tumors. But you also can see here is that the mortality stays stable, which suggests that there's at least overdiagnosis and maybe also over-treatment. There are different types of thyroid cancer, of which differentiated thyroid cancer, which comprises both papillary and follicular thyroid cancer, to be the most frequent. Then we have also biliary thyroid cancer and aggressive thyroid cancer, which I will speak on the last part of this presentation. So according to the latest APA guidelines, the treatment of differentiated thyroid cancer is based on the total thyroidectomy if the tumor is larger than 4 centimeters, or there's extrathyroidal extension, or there are lymph node or distal metastases. And if the tumor is smaller or these other factors are not there, then a hemothyroidectomy or even active surveillance is enough. Following total thyroidectomy, radioiodine therapy is usually given after thyroid hormone withdrawal or after recombinant human PSA stimulation. However, These guidelines state that this need for therapy depends on the risk stratification, also the classification. So we see nowadays a lot of patients that do not receive radioiodine therapy. Afterwards, patients are treated with PSA suppression using Levothyroxine, you can see here. So if you look at the prognosis of differentiated thyroid cancer, it's relatively good with a 10-year disease-free survival of papillary thyroid carcinoma of around more than 90%, and of follicular thyroid carcinoma of more than 8%. However, this prognosis is also based on the stage of the disease, because in papillary thyroid carcinoma stage 1 disease, the 10-year disease-free survival is more than 99% in most of the cases. Thyroid cancer does more frequently occur in females, and what you can see here in the graph is that it's one of the most prevalent cancers in women of reproductive age. And as the prognosis is relatively good, as I stated, there also you can see that the quality of life of the patients that survive the thyroid cancer is relatively decreased compared to the general population, and even at the same level as patients with cancer with worse prognosis. And what we can see is that younger age, female sex, and persistent hyperparathyroidism result in a lower quality of life, as we and others showed. So this lower quality of life in younger females might have to do with the desire to have a child, as we showed that in one of our studies that we see diagnosed and treatment negatively influence desire to have a child in almost 40% of our female patients. And this was either because they just didn't want to child anymore, or there was a fear of medicalization of pregnancy. So these are very important things to remember when seeing such relatively young patients. So therefore, the treating physician should have an active role in providing information and support. This is emphasized by the fact that the psychological distress is also related to suboptimal fertility and also pregnancy outcomes. So important uncertainties that need to actively addressed related to the timing of the treatment, the potential risk of radioiodine treatment, pregnancy-specific thyroid cancer progression or recurrence, the potential risk of PSA suppressive therapy, and also the risk of adverse obstetric and childhood outcomes. So the document presentation is largely based on a review that Angela Leung, Tim Korvar, and I published last year. So you can also look it up afterwards. So I start with pregnancy and different thyroid cancer diagnosis. The first case, we saw a 30-year-old female at our patient clinic of the thyroid center that was referred for a second opinion because of a thyroid nodule during pregnancy. History was 2 years ago, there was a thyroid nodule on the left side of approximately 4 centimeters, and there was an FNA performed, which showed the TSA2, so benign. But since a few months, there were signs of growing of the nodule. She had no mechanical complaints, and at this moment, she said 12 weeks pregnant when she visited our patient clinic. There's no family history of thyroid cancer, and she also don't use any medication except for the vitamins that are prescribed during the pregnancy. So a physical examination, I felt a node on the left side of the thyroid of approximately 4.5 centimeters, and there were no enlarged lymph nodes in the neck. So draw the thyroid function, that was normal, and the thyroid ultrasound that was already performed to the other hospital at 7 weeks pregnancy showed a node on the left side of 5 centimeters with no lymph nodes, and there they did an FNA and it showed a TSA3. So we saw at 12 weeks, but we waited a little till 18 weeks to again perform an ultrasound, and that even showed a larger nodule of 6.5 centimeters. Again, no sufficient lymph nodes, and the FNA that was performed showed the TSA1. So here you can see a graphical overview of the size of the nodule, and you can see that it seems that it's in the last weeks, it grows very fast. And now she's 18 weeks pregnant, as I said. So, and yeah, the FNA showed the TSA3 and the TSA1. In the past, it was the TSA2. So we discussed results with the patient and the family to opt on diagnostic hematoidectomy or just wait and see what happens. So in the end, we and she decided to go for a diagnostic hematoidectomy within 2 weeks. So she was operated at around 20 weeks. And the surgery went well. There were no complications, and she could be discharged the next day. But the pathology showed a follicular adenoma of 4.5 centimeters, which is fine, but there were no signs of malignancy, so it's benign. But it's a little bit strange because the ultrasound showed a lesion of more than 6 centimeters. So yeah, that was something that we still don't know, know totally can explain that. The pregnancy went on, and son was born at 39 weeks, and there were no complications, also no problems with the son, and the child is doing very well. So that brings us a little bit back to the physiology during pregnancy. So what we see is that the size of the thyroid gland increases during pregnancy about 10% in iodine sufficient areas, but it can be up to 40% in areas with iodine deficiency. And also the serum thyroglobulin concentrations increase during pregnancy, especially in states of insufficiency for iodine. And you see that after the pregnancy, the thyroglobulin values go back to their baseline values. If you look at the thyroid nodules, if you make ultrasound in adults, you can see up to 70% of the adults have a thyroid nodule imaging, and approximately 5% have a palpable thyroid nodule. And during pregnancy, when you do those ultrasounds, you see that about 30% of the women, which are younger, so this might explain the difference, also be a nodule detectable. And again, in about 5% have a potential palpable nodule of greater than 1 centimeter. So the evaluation of thyroid nodules discovered during pregnancy or postpartum are almost the same as in non-pregnant, non-lactating population. And we first start with the thyroid function, and if needed, we do an ultrasound with subsequent FNA if that's needed. However, it must be noted that pregnancy is a contraindication for nuclear imaging, so no iodine 123 scans or technetium scans could be made if you think there's a hyperfunctional nodule. So what do the guidelines tell us if we detected the thyroid cancer in pregnancy? Well, if it's diagnosed early in pregnancy and there are no lymph node additional metastases, the advice is to do monitoring using ultrasounds. And if the cancer is diagnosed later on in pregnancy, then it's advised to wait and do the surgery after delivery, which is also the case when it's detected early in pregnancy. However, in case of rapid tumor growth or the presence of development of lymph node metastases, you could consider surgery, and if you want to do that, then advise to do it in the second trimester because it gives least risks for both the mother and as the fetus. Here, there are also studies performed in patients that were diagnosed in pregnancy and who underwent thyroid surgery. There are 2 studies in a total of 53 women, and the most patients were operated during the second trimester, and these studies showed no pregnancy losses, and also neonatal and maternal outcomes were similar to the general population. So then about the perinatal period, the pregnancy and differentiated thyroid cancer treatment. Again, a case, this time a 37-year-old female who was referred from one of the surrounding hospitals because of newly diagnosed BTC with lymph node metastases. And she had no menstrual history, and she had a few months signs of a growing lump in her neck. Again, no mechanical complaints. She already has 2 children, but there's still a pregnancy wish, and further she used no medication. So thyroid function was normal, and the thyroid ultrasound showed a thyroid nodule on the right side, approximately 2.6 centimeters. The FNA was performed, showed that it tested 6. And there was also sufficient lymph node in level 6 of 7 millimeters. And the FNA of that showed the metastases of a papillary thyroid carcinoma. So total thyroidectomy was performed with central lymph node dissection on both sides. Surgery went well. And the pathology showed the papillary thyroid carcinoma of the testicle size 2.7 centimeters. And the 2 out of the 28 lymph nodes resected showed metastases of the largest of 1 centimeter, and there was no extranodal growth. So it is a P2, N1A, and X tumor. So it was planned for radioiodine therapy after thyroid hormone withdrawal, as is described in our national guideline. But then she states that she's still breastfeeding her newborn child, and she still has also an active pregnancy risk. So first, what to do with the breastfeeding? So the guideline for the ATA states that the lactating breast concentrates iodine, and therefore breastfeeding must be stopped for around 6 weeks before up to 3 months after the radioiodine therapy. And this is to protect the mother's breast tissue from the radiation, and also the infant starch gland from ingestion of the iodine, radioactive iodine to the breast milk. Further, it's also interesting what the influence of the right treatment is on pregnancy outcomes, but also on the prenatal function of the females. So first, about the pregnancy outcomes. Well, several studies showed that there's no increase of adverse obstetric outcomes, that is spontaneous abortion, stillbirth, preterm births, or congenital malformations in patients treated with radioiodine therapy. I didn't have the reference here because there were too many, but you can look it up in our paper. However, recent meta-analysis shows when comparing patients that females with radioiodine therapy that received it shorter than 1 year compared to that received it later than 1 year, that showed that those who get the radioiodine therapy within 1 year, they have a higher risk of abortion compared to those where they get pregnant later on. However, it's difficult to judge whether this is confounded by indication or this is real, because it wasn't stated in the paper if this was spontaneous abortions or induced abortions, because one might think that when a lady gets pregnant 3 months after radioiodine therapy, that she got scared of what the radioiodine therapy will do on the child and then maybe have an abortion. So it gives, maybe this study gives a sign, but that can't explain everything. This is another systematic review meta-analysis that looks at the risk of congenital malformations in patients that receive radioiodine therapy compared to controls, and it showed that there's no increased risk of congenital malformations after radioiodine therapy. So the ATA guidelines recommend avoidance of pregnancy for 6 to 12 months after radioiodine therapy. And yeah, and I think there are a lot of studies backing this up. Only the question is whether this should be 6 or 12 months. That I think could be used in the future. So if you look at the prenatal function, several studies show there's a transient change of the menstrual period during the first year after radioiodine therapy, and there's also a transient increase of FSH during this first year. However, there were no increased infertility rates. But what was seen is that the median age of menopause was a little bit lower in those who received radioiodine therapy compared to those who didn't receive. If we look at the gland function itself, there are recent studies that use the anti-mother hormone, the AMH concentration, as a marker of ovarian reserve. And this idea is that it reflects the size of the primordial follicle pool and also declines gradually with age, and it's undetectable at menopause. And the idea is that it's relatively insensitive to inter and intracycle variability and contraceptive use. So this is again a systematic meta-analysis that looks at the change in AMH concentrations at 12 months after radioiodine therapy compared to baseline, and it showed that there's a significant decrease of the AMH concentrations after 1 year compared to baseline. So we saw in the previous slide, we also studied that ourselves, and what we saw is that during the first year after radioiodine therapy, the AMH levels increased significantly, and thereafter it stays more or less stable, or it does slight increase, what you would expect when females getting older. And here we compared somewhat younger females with some older females, and we showed that the AMH drop in the older females was significantly higher, although they received approximately the same dose. And also what we saw is that in the above 35 years old group, there were more patients that got into menopause after the radioiodine treatment, and when they were the mean age after treatment was 44 years. So the conclusion of that is that in women over 35 years of age with desire for pregnancy and without high-risk human features, a less aggressive radioactive iodine strategy should be considered. Then about infiltrated thyroid cancer during pregnancy. So we did not with the case. So we were with her that she should first stop the breastfeeding. So she stopped that for about 2 months, and then she received the radioiodine treatment after thyroid hormone withdrawal. And the post-treatment scan showed a small thyroid remnant, and with a PSH of 170, that's due to the withdrawal, and TG was 0.7, so relatively low. So that we have no discipline tests, and so we diagnosed it for this stage 1 disease. So the plan was to do PSH suppressive therapy and do follow up with the TG measurements and also an ultrasound after approximately 6 to 9 months. But then after 5 months, she called her outpatient in clinic because she's pregnant. At that time, she had short medication on levothyroxine, 125 milligrams a day, and her blood test with local PSH that was a little bit suppressed with a 3 to 4 that's a little bit elevated, and it's a TG of 0.2, so relatively low. So what about the asking for replacement and in pregnancy? Well, what is usually the advice is to increase the levothyroxine dose by 25 to 30% from a positive pregnancy test. And this is based on the physiology that you can see on the right picture. And basically the red line, you can see that during pregnancy, usually the 3 to 4 is increasing. It peaks around 10, and then probably goes a little bit lower again. But to mimic that in patients that doesn't have a thyroid anymore, you have to increase the dose. And from this very nice mentioned paper in 2004, it can estimate that you should increase the dose by 25 to 30% and do it upfront, because otherwise you are a little bit behind every time. So that's what we usually advise. However, it is known from a lot of studies that lower TSH and higher 3 to 4 concentration in pregnancy have been associated with preeclampsia, small for gestational age, lower child IQ, and also less cerebral brain mass. So therefore, the harms and benefits of TSH suppressive therapy should be weighed on while considering the risk of adverse pregnancy outcomes. Also, what is important to note is that when you just increase the dose by 25 to 30%, in a female that already has a very low TSH, it might be that you're totally overfeeding the women. So what we usually do is that we first check the thyroid function to see when they have a positive pregnancy test how the thyroid function is, and to a little bit see when we should increase the dose, if it's now or we should wait a little bit. And sometimes we increase not by 25, but a little bit less or a little bit more if needed. So what do the guidelines say on the TSH goals? Well, it states that the pregnant women with thyroid cancer should be managed at the same TSH goal as determined preconceptually. So in case of an excellent response, the levothyroxine treatment should be targeted at a TSH level of 2.0 during pregnancy. And in case of an active DTC, well, the target should be less than 0.1 during pregnancy. However, as I just stated, you should still weigh the harm of the suppressive therapy. What are the benefits for the thyroid cancer or the harms, and what are the risks of the adverse pregnancy outcomes? So, what about the disease course during pregnancy? Well, there are several studies that demonstrated that there is no significant disease recurrence or worsening of structural disease during pregnancy. This is one of the interesting studies from 2017, where they looked at the pre-pregnancy clinical status and then looked whether there was clinical significant structural disease, recurrence, or progression that leads to additional therapy. What you can see is that the excellent, indeterminate, and biochemical incomplete response group, there was no significant progression during pregnancy. Only that the TG levels were after pregnancy slightly higher than they were before. But what you can see in the structural incomplete group is that in 3 out of the 30 days, so that is 8%, there was a clinical significant progression. These three patients, 2 of them were operated afterwards because of the lymph node recurrence, and in 1 patient even had to start a PPI. But the main problem with this study is that there was no control group, so we don't know what would happen if the females were not become pregnant. So it might be that also without the pregnancy there will be recurrence and they should be operated or using the PPI. So that's a difficult thing. Well, the guidelines state that in case of an excellent response, that there's no additional monitoring needed during pregnancy, and if there's a biochemical or structural incomplete response, additional monitoring with both serum TG levels and surveillance neck ultrasound should be performed. So because a lot of patients with ultrasound nowadays, we see a lot of small tumors, and the tendency the last years is to don't go for surgery but to do surveillance, and so there also surveillance done in patients that want to become pregnant or that became pregnant. So this is a study from 2016 from Japan in 50 women that were on active surveillance, and that showed that during pregnancy, 4 of them an increase of the tumor of more than 3 millimeters occurred, and there were in 2 of them they were operated after delivery, and the other 2 were at the end of the study still on active surveillance. So there was increase, but 8%, but it led to surgery only in half of them. So, but again, yeah, also there's no control group, so we also don't know what happened when if they weren't pregnant. So the latest ATA guidelines advise to monitor these microcarcinomas with a neck ultrasound each trimester of the pregnancy. However, based on both the physiology but also on the study that I showed, it could be argued that it's not reasonable to perform or it's not needed to perform 3 ultrasounds, but maybe just do it only once in the second trimester. If there's really growth, then you might go for surgery if needed in the second trimester. But that's something up to discussion, I think. So with our patients, because the TG levels were low and was used a little bit suppressive, but not that much, we thought, well, we can just continue the dose and then follow it up and see if we should increase it. And we plan to do an ultrasound in the second trimester because this was just 5 months after the surgery, so we didn't have the proper restaging yet. Then about medullary thyroid carcinoma, this could be either sporadic or hereditary due to a red germline mutation. And usually these patients present in the 4th or 6th decade. But in the germline mutation, they can also be much younger. They're treated usually with a total thyroidectomy, including a central lymph node dissection, and typically they don't receive radioiodine therapy because that does not work. And they receive thyroid hormone replacements, but don't receive TSH suppressive thyroid, so they're forced to just keep them euthyroid. In the case of extensive disease, one could consider local radiotherapy or systemic treatment with a PPI. So the consideration about pregnancy in the perinatal period, when diagnosed with pregnancy, both the ATA and the British thyroid shaping guidelines for surgery due to the more aggressive nature of the NPC. I think that this also depends on the size of the tumor, and you can also opt, like in DTC, for follow-up, but it really depends on the situation. So this is something to discuss in NDT. So there are no studies on disease progression and recurrence in pregnancy in women with an NPC, but one might consider performing a thyroid ultrasound containing serum calcitonin and CA measurements during the second trimester. And the target TSH levels during pregnancy are the same as in non-pregnant women, so the target around 2 or 2.5. In the classic thyroid carcinoma, well, this is a very rare disease, and it's in general extremely aggressive. And well, it's a study from the Netherlands showed this year that the 1-year survival is around 12%, so very low. And usually immunotherapy is needed, and therefore, in case it's made during pregnancy, surgery should be deferred to after delivery. And if surgery is not possible, PPI treatment can be considered. However, in most studies, it showed that PPI are toxic for the fetus. But yeah, that's something also to discuss with the patient, I think. So to give a short summary of what I stated, well, it's usually advised to defer the DTC treatment after delivery, as a delay would not pose a threat to both the patient and the fetus. However, if surgery is necessary during pregnancy, it should be performed in the second trimester. Further, it's recommended to avoid pregnancy for 6 to 12 months after the radioiodine therapy for DTC, because further research is needed to better define this period. And also, a less aggressive radioiodine treatment strategy in women over 35 years of age who have desire for pregnancy should be considered if that's possible. So pregnancy seems not to be associated with a significant disease progression of previously treated DTC or micro-PDC under active surveillance, and the need for TSH suppressive therapy during pregnancy is based on the DRS status. But the harms and the benefits of this suppressive therapy should be weighed against the risk of the first pregnancy outcomes. So what is very important to note is that the preconception and perinatal management and surveillance should be based on careful decision of the prognosis, the therapy, fertility issues, and the risk of the first pregnancy or child outcomes. And it should be done in a multidisciplinary team, should be with the woman, and if there is a partner, also with the partner. So really discuss with each other what to do, and yeah, that's I think a very important point. So if you want to read more about this, can refer to the 2015 thyroid cancer guidelines of the APA, and also about to the thyroid disease during pregnancy. This was 2017. It's to be noted that right now they're both are revised, or the revision, and well, I think at the end of this year, beginning of next year, there will be new guidelines. So really looking forward to those. So I want to thank the people from our medical center, especially Tim Korenvaart, for the help to finding the paper, and also for the UCLA also for help with the paper. And I want to thank you for your attention. Yeah, I think the floor is open for questions and discussion now.
Thank you, Dr. Velsen. So we're gonna switch now to Dr. Davies, and after that we will have more time for questions.
Okay. All right. Thank you very much, Evert. Can you hear me okay?
Yes, we can
Good.
hear you well.
So I sat down last night to think about what I would say. And Mark Kirkin always likes us to say something new, right? Or controversial. And I think he relies on me for that. Not so easy, Evert, right? Not so easy. I thought that was a very nice review, and it's a nice short review paper, putting into perspective the three sort of types of patients we see: those who are hypothyroid from thyroid surgery, those with nodules, and the rare, thank goodness, patient with thyroid cancer, either before or particularly during pregnancy. So the management of those patients is very similar in the US as it is in Amsterdam. We tend to use a little less radioiodine, probably. We tend to have molecular diagnosis available for us, so that we're not satisfied with Bethesda 3 generally. But otherwise, things are very similar. American MDs tend to be a bit more aggressive in their approach to patients, which I'm not in favor of. I think we need to be calm, cool, and collected, just like you. So I'd like to raise a question that I think is right, and that is, why on earth is thyroid cancer not worse in pregnancy? All right, so let me put a couple of slides up if I can. Oh, where is it? I suppose it's going to be this one. I hope you see my slide now. Let me just.
Yeah, we can see your.
You see the one slide or you see both?
We don't see the presentation mode, we just see the PowerPoint. But we see the slide though. We see one slide.
So let's not waste time. So I raised this question of why cancer is not more dangerous in pregnancy. In fact, Evert just showed the data that there isn't much progression during pregnancy. But if you look in the basic science literature, the exact opposite should happen, right? And I don't understand it, and I don't have any answers for you. All right, so this particular growth factor from the placenta increases during pregnancy, as you would expect. And it doesn't seem to have many effects systemically. But in contrast, all the other growth factors that we know of are increased during pregnancy. Now, do you see this next slide?
We can see it.
Good. So IGF-1 and 2, right? EGF, PDGF, FGF, TGF family are all increased. And this is a systemic response to pregnancy, right? So these growth factors are circulating in the mother's serum and should have an effect on any thyroid cancer that remains or has been found during pregnancy. So the one that's I want to make a mention of for everyone is IGF-1. IGF-1 has very strong growth, differentiation, and survival influences on cells, including thyroid cells. And the point I'm trying to bring, well, here's some examples of IGF-1 causing thyroid cells. These are lines, but they're causing thyroid cells to grow. And why doesn't that happen during pregnancy? And I think we'll skip this one. And here's a classic. If you don't remember anything from anything I'm saying, this is from 1986. It's a paper by Sidney Ingbar, who was one of the great investigators of thyroid cell biology. And it's called the fact that IGF stimulates the growth of thyroid cells by synergizing with TSH. So now we've got a woman with an increased IGF, right? And now we learn that any circulating TSH will actually synergize and cause even more effects. And this effect is caused by some type of crosstalk between the IGF-1 receptor and the TSH receptor, which we don't need to go into here, except to remember that having IGF-1 and TSH in the circulation is, in fact, a combination for thyroid growth. Now, whether this just explains the hypertrophy of the normal thyroid in pregnancy, but it raises the whole question of, should a suppressed TSH be the aim in thyroid cancer? And this is certainly one biological explanation of why we try to suppress the TSH in a non-pregnant woman, right? Because there's some evidence that the outcomes are better, although the evidence is not very good. But there is a logic to the suppression, right? And yet we don't want to do that in pregnancy, because we know that suppressing the TSH causes a variety of problems. And therefore, the cancer cells should remain at risk of stimulation and growth. So why is pregnancy not a dangerous time for thyroid cancer? Now, I don't have an answer, but it's a serious question. Here are some possibilities. So I put some conclusions together that pregnancy physiology must inhibit the consequences of thyroid cancer stimulation. It's not possible to avoid that conclusion unless the data are wrong. Now, the data could be wrong because they're very small. I mean, the studies of thyroid cancer in pregnancy are very small studies. And thank goodness, we don't want thousands of patients available for us. But it could be that Evert's conclusions are quite wrong, that in fact it is dangerous in pregnancy, but we're not seeing it, right? On the other hand, he could be 100% right. And I'm sure his colleagues would say he is, right? Tim's always 100% right? So there are some possible explanations that I was thinking about, although we need to think more. And one is that there must be some interference with growth factor action in pregnancy. And this could be something we don't know about from the placenta, or it could be cytokines and chemokines that are often increased in pregnant women. And it's a great area for research, because as far as I know, I may be wrong, but I don't think anyone's looked at this ever. And it's a question that remains open. So that's what I wanted to raise as a talking point or a controversial point. Hopefully the New York Times will take it up and make it a national problem. But the physiology of pregnancy is absolutely fascinating. And to tell me, as a semi-biologist, that thyroid cancer doesn't get worse in the presence of growing concentrations of growth factors, doesn't all go together. Thank you for letting me talk.
Thank you, Dr. Davies, and again, thank you, Dr. van Velsen, for wonderful interventions. I wanted first to pass it to Dr. Brett and see if she has any reflections or questions for the panel.
I did have two questions. One question is, with the radioiodine, why is it that we have to wait 6 weeks prior to radioiodine to stop lactating?
Yeah, I think that's a good question. Yeah, I think the idea is that there's still some that is the activity of the glands that should be get a little bit lower, so they're not that active anymore. So then they have less they take less iodine in it. I think that's the thing, but I'm not 100% sure how the physiology works of that. But that was my idea when reading it, at least.
Okay. And my second question is, I was a little surprised about when I read in your paper about the risks of replacement of, or TSH suppression over replacement of with levothyroxine in the thyroid cancer patients and the risks to the pregnancy. And we usually don't get too concerned about just suppressed TSH during pregnancy, and usually mild hyperthyroidism is well tolerated during pregnancy. And was wondering if this is a trimester-based risk. Is it that the risks to the pregnancy are higher, say in the third trimester, and if it's not such a risk in the early in pregnancy, and perhaps a risk later in pregnancy with over replacement?
Yeah, I think these results are coming from the epidemiology studies that we have done. My colleagues did in the Generation R study. They showed there all those risks of obviously the higher frequency 4 with the lower IQ, with the higher chance of abortion and higher pregnancy complications. So I'm not know by heart in which trimester they measured the fit score in TSH. I thought it was in the second and at the beginning of the third, but I'm not 100% sure. But these, yeah, most of these results are from the epidemiology study, so we don't have any randomized controlled trials on this, as far as I know.
And we welcome here Dr. Mark Urken, and just join us as a panelist. And since you are here, Dr. Urken, let me pose a question to you. Being a surgeon and treating sometimes patients with thyroid cancer during pregnancy, I would imagine that the main or the worst thing that can happen is hypoparathyroidism in these patients that might be having significant consequences for the mom and the baby. Other than that, I would think that surgery is otherwise quite safe. Can you tell us more about that particular decision-making as a surgeon when you have a patient that has perhaps a large nodule or active thyroid cancer that you will take it to the OR?
Yeah, well, first of all, thank you. And thank you for these, for a wonderful presentation. And Dr. Davies, thank you for always educating me whenever I listen to you. And I have a question for Dr. Davies after I respond to that. But yeah, I think if I look back at my career, the number of patients that I've taken to surgery during the second trimester, it's really very limited number. And it's, I would say that it's primary, can count on one hand the number of those patients. And I really have to be talked into that decision and really convinced that it's a necessary intervention. So fortunately, it's extremely rare. My decisions regarding the diagnosis of thyroid cancer during pregnancy really are based on a second trimester follow-up ultrasound to make sure there's nothing that is evolving. But in the vast majority of patients, my job is to really provide confidence to the patient and her family that she's not putting herself at greater risk by waiting until she delivers. But with respect to any particular surgical detail, I would agree with you that hypoparathyroidism is something that we really want to be extremely careful about, but probably no more than what we do on a daily basis. So I have and JP, if I could just ask.
Yes, please go ahead.
Quick question. So Terry, I'm fascinated by the TGF-1 discussion. Are you aware of any studies that have been done either in an animal model or in vitro looking at the impact of TGF-1, perhaps in combination with TSH on thyroid cancer itself?
Mark, thanks for the question, and I'm not aware of that at all. One of the problems with this is that Sidingbar died in 1988, just after a series of papers bringing the IGF-1 and TSH together synergistically, and there was a a period of time where nobody really remembered this until the whole era of thyroid eye disease opened up, with Smith showing that this was happening in fibroblasts from behind the eye, that IGF-1 and TSH were coming together. And so there's a lot of work not done other than on fibroblasts, and not so much done, as far as I can see, very little done on thyroid cancer, other than the fact that these growth factors make thyroid cells grow. Right? So the answer is not much. I'll look in the literature again, because this, as I said, I made this all up last night, so I haven't had a lot of time to pursue it, because cancer is not really, something we do. But this is a really interesting area I might like to pursue. I do have something else to teach you, Mark. And since this is often a surgical audience, I have to tell you, I just gave a quick talk on the history of thyroid surgery. Well, not so much surgery, the history of thyroid. And I was looking at some of the old surgical reports from when they first started doing thyroidectomies for big goiters. And of course, they got madness and tetany and everything. But what was their explanation? It wasn't anything to do with the thyroid gland. Those surgeons thought they had interfered with the blood supply to the brain. By taking out the thyroid, somehow they had disrupted the blood supply to the brain. And that was the explanation. Of course, that delayed everything for years. But people just could not believe that having a big thyroid, right, meant that you were short of anything. They were taking the thyroid out because there must be too much of something, right? And so it got a very dirty story there, really. But it's fascinating.
I suspect that may have led to some madness amongst the surgeons as well. But yeah,
they stopped doing it, right? They stopped doing it. Yes. Yeah.
Dr. Davies, following this idea of IGF-1 and TSH, teprotumumab for thyroid eye disease should be although of course the people getting these medicines is quite small. Wonder if somebody has tracked changes in thyroid nodules. The majority of these patients will have ultrasounds because of Graves' disease at one point. That might be interesting. Yes.
Terrific question. Terrific question. Perfect for you to do. Right?
But you say that you're interested in that.
But well, there've been, this IGF-1 receptor antibody that is, on TV and in the papers and everywhere, has made this company, a couple of $1 billion, because anyone with Graves' disease and sees a slight change in their eyes, they want treatment, and they're all rushing to the ophthalmologist, not to us, not to the endocrinologists. Right? And so Horizon have made a fortune, and probably enough to be able to withstand all the lawsuits for hearing loss that a few patients have experienced. So I think that's a story that's, those patients are there to study, but you'd have to go all over the States for that. Yeah. It'd be very hard to get a large number, right, to follow the nodule, but I would. I've seen a few nodules get bigger during pregnancy, but nothing like you would expect, what I would expect when I read about all these growth factors. So even the nodules seem to be protected, but it's not well documented because Evert doesn't work hard enough, you see, and he's not looking for all these nodules in pregnancy and measuring them carefully in association with growth factors. But tomorrow he will.
And we have a couple of questions from the audience. Dr. van Velsen, this is you mentioned the effect of radioactive iodine on ovarian reserve of measuring AMH, anti-Müllerian hormone, and there is a question whether there has been there are patients with PCOS that actually have high AMH. There's a question here whether this has been explored to these patients that have PCOS get radioactive iodine, for instance, whether these actually get better, or the severity of PCOS.
Yeah, I think it's a good question. It's a good idea. Yeah, I'm not sure. Yeah, I'm not aware of those studies, but yeah, and I'm not sure if the AMH levels in PCOS are related to complaints. I'm not into the gynecology that much, so I'm not sure. But if so, then maybe it's a chance of doing something. But yeah, then you have maybe the side effects of the other side effects of the radioiodine therapy on the thyroid itself. So yeah.
Yep.
Yeah, the question is, what are you doing then? If you're doing any good for the patient. So, yeah, it's an interesting idea.
And thank you for that. And Dr. Davies, one of the questions has to do with the fact that, the tumors don't grow and things like that. You were exploring reasons for it. One question is it maybe the case that is because we actually have these patients by nature or by levothyroxine replacement with suppression TSH. So having suppressed TSH, either because a pregnancy will be a factor to explain that.
Well, I mean, in normal pregnancy, the TSH is often suppressed in the first trimester, but in patients who are on thyroid replacement, we tend not to keep the TSH low throughout pregnancy, at least I don't. So I don't know whether I'm doing the right thing or not, because according to me, the TSH should be suppressed to keep it, right, to keep it down. But on the other hand, I am concerned also about side effects of a low TSH. Now, Elise Brett mentioned that she thinks that mild thyrotoxicosis is well tolerated in pregnancy. And I agree, in Graves' disease, that's true, because after the first trimester, the Graves' disease, certainly in mild patients, pretty much gone away, because you get a tolerance, an immune tolerance coming on right by the end of the first trimester. But in patients on thyroid hormone replacement, I don't know that there is such great data, Elise, on obstetrics problems from having a low TSH. I think most of those studies are based on patients with Graves' disease, but I could be wrong. Maybe there are some studies. I'd have to look. Maybe you know better. But I agree with you. Mild thyrotoxicosis, I don't treat in pregnancy. And I try to stop everybody else treating them because, these MDs, they're dangerous. And they'll be treating, a 0.3 TSH with methimazole. Absolutely no reason whatsoever.
Fantastic, and I would like to thank the whole panel, each of you. Fantastic presentations. I think we have learned from you a lot. Thank you to the audience for the questions. Invite you to attend our next virtual session next Friday. And again, thank you, and take care.
Thank you.
Thank you.
Yeah.
Thanks, everybody.